to retina, and here we have Dr. Mahesh, the dynamic young president of KSOS and renowned vitreoretinal surgeon from Cochin. He'll speak to us on expanding horizons in resurgery after diabetic vitrectomy.
Thank you, Dr. Thomas. So, what did I do differently this year? Actually, this is not this year. In the last probably few months or few years, I have been trying. See, our main patients are diabetic retinopathy patients for a VR surgeon, and many cases we fail due to the pathology of the disease. We are fighting against ischemic retina. Many times we do vitrectomy, then it comes back. We do TRD, it will not settle all ischemic retina, sclerosed vessels. So these sort of cases we try once and then leave it. Most of the patients will become no PL in the course of the time if the surgery fails. That is the problem with PDR. So last 1 year I have started reoperating this one more time, and some of them have given good result. Like this was a patient. This patient, this had a recurrent vitreous hemorrhage. In fact, other eye is NVG, no PL. So, since it was recurrent vitreous hemorrhage with 1 or 2 meter, I did posted for a vitrectomy. And as usual, we tried to induce PVD with cutter itself. It was a very adherent vitreous. Then cauterize the bleeding points, give good laser. It's a clean surgery. So, there was no bleeding at the end of the surgery. So just put air and stop it. So this is just a vitrectomy, membrane peeling, endolaser, and this was the result. 1 month he was doing well. He started reading 618, N8 and all. Then it redetached again. Then I took the patient again. Initially I thought it's a bad case, we will leave it. But since it is one-eyed, I took it again. Then I had a hell of a time inside the eye, because there was a complete sheet of membrane within 1 month proliferating across the retina. So this is that, and that too, that membrane was something like a rubbery, cheesy sort of. It is coming piecemeal like this, and the importance of peeling is shown in this video. Complete removal, and from arcade to arcade there was membrane, so it was peeled like this throughout. Luckily there was no bleeding during the surgery, since it's already very well lasered. So till the periphery, till the vitreous base, it was separated. Then it was removed with cutter, and without much of a problem, I could separate without much of a iatrogenic break creation also. And decided that since it is one-eyed and recurring problems like this, we thought we will put oil after a good laser. So this is the final membranes peeled in the periphery. So basically this is an anterior hyaloid proliferation or even pan-hyaloid proliferation with membrane proliferation under the post-vitrectomy. So did the FAE, gave laser, it was quite good, and then gave laser like this to the fill-in laser, and then put silicone oil. So this is injection of silicone oil, retina is attached. And at the end of the surgery, post-operatively, he was doing well. I was expecting whether he is going into NVG, but he did well with around 6/36 and 36 sort of vision, and he is maintaining for the past 6 months. So this is the importance of resurgery in PDR failed cases, especially reproliferations. So I feel especially in one-eyed patients and all, if you are doing this, can salvage some vision. So that is just. Thank you.
Thank you, Mahesh. Please stay there. The key to a failed vitreoretinal surgery, be it in diabetic or even in a rheumatogenic RD, is almost always a membrane. So always go and search for a membrane if you have a recurrence. It should be there somewhere. It's not due to a fresh break. It could be a secondary break, but it's almost always a membrane, and search for it. Second dictum, your first surgery you might go without an air, with gas, but if there is a recurrence, better to go for oil. So I feel that is the message that Mahesh has given.
Yeah. And you have to keep trying, especially in cases like this, even though the prognosis may not be always good. So that is, this patient is quite happy, ambulatory. So that is one thing.
Yeah, and here again, the prognosis doesn't mean he's going to reach 6.6.
Yeah, that's what. 660 is inadequate for his daily.
That should be very clear on the surgeon's part as well as on the patient's part, that what we are striving for is to attain this navigable vision.